Hey guys, it's been a while since I've done this. I've been working on some other things on the side. Had a MDT study group this week, working on CEUs, so I've been away from things for a little bit. Yeah, welcome back. So where we left off, your follow-up evaluation. Confirmation of provisional classification may take up to 5 visits. If you follow the Wernicke articles, I think it's Wernicke. If you just Google Wernicke Mark, Hart DL, I think it's Dennis. You'll find the research behind centralization and peripheralization, and that could take up to 7 visits in some of their research. And if it's not found within 7 visits, assuming you're treating that patient with a mechanical mindset, you're going to end up with a poor prognosis. Provisional classification. When I go into my evaluation, after the subjective portion, I have a provisional, being derangement, dysfunction, postural, or other. Right? My goal with the objective portion was to disprove my provisional. Okay, I don't want to go in there with the bias to say, okay, you're going to get better. I need to disprove it. Okay, and so if the patient at any point in time doesn't respond predictably compared to what my provisional classification is, then that starts to disprove my provisional. I have to go back and rethink what did I actually do. So now you're giving the patient the exercises to work on at home. They come back in. The first question is, I saw you on day 1, and all of my students can attest to this. I saw you the last session, and this is what we gave you. Did you get a chance to do your exercises? Yes? Awesome. What effect did they have? Are you better, worse, or overall the same? If not, why didn't you get the exercise in? There's a few reasons that I will allow for, for not getting the exercises in. Family, traveling, and other health issues. And so, that's me going in with my bias, right? And so if you're traveling, that might have been my fault. We weren't prepared for you to be traveling, so I might have given you the exercise that you couldn't do while you were traveling. My fault. Other health issues, all right, it is what it is. Family, life, it happens. So I'll do my best to talk to the patient to really, hammer down the value of doing the exercises and or the movements in terms of what they're going to feel. And then day 2 becomes day 1 again, just trying to emphasize that the patient should get better with this exercise, going through your classification, ensure that you did everything correct on day 1. You should come back to the same result as you did on day 1. And then from there, you give the same movement, but maybe a different version of it, or a stronger educational base as to why that movement is important. If the patient is better, are you a lot better or a little better? And what makes you say you're better? So if the patient is a lot better, awesome. Green light, continue. If the patient's a little better, they may be trying to just please the therapist. That's a little better isn't enough for me. I really want, and I rephrase the question maybe a third time and say, okay, so you say you're a little better. Would you say, wow, I'm better? Or just a little better? I'm looking for that wow. If it's just a little better, then I'm going through and rechecking, did I do everything correctly? If worse or unchanged, have you been doing the exercises? How frequently were you doing the exercises? What exercises have you been doing? It's not uncommon, I'm sure a lot of us that have experience, the patient will essentially just redo the entire exam, or we didn't give the patient enough education that they should be stopping some of the other exercises that they used to do in the, essentially to help us with our experiment of determining whether or not our classification is correct. And then, are there any problems that limit you from doing the exercise? Did I give you a floor exercise when you can't get down on the floor? Or did I give you a lying down exercise when you spend your whole day sitting? So did I just give you the wrong version of some exercise? And what happens immediately after the exercise? Always look for the symptomatic response. Almost always look for the mechanical response. And then some of the other things that we're looking at here for the things to review are the treatment. So, two methods of clinical reasoning. I covered this previously in a Facebook Live when we started talking about, is there one type of back pain? I think it was the Keating and Kent article. I don't remember if it was 2003, 2004. You can go back in my Facebook Live feed and check that out. But pattern recognition, this is only available with experience and a well-organized knowledge base. And this hypothetico-deductive reasoning, otherwise known as the HOAC model, is what students are learning in school. This is hypothesis-oriented algorithm for clinicians. And this is try and see until the treatment pathway is defined. And so you're essentially doing continuous reassessment. It's that whole test, intervention, retest, test, intervention, retest, test, intervention, retest, until you start to figure it out and narrow it down. Data gathering, you're constantly taking in information from the patient. It requires empathy and active listening, and this is your first opportunity to create a hypothesis. This is all performed during your subjective. Knowledge base, we have the knowledge coming out of the doctorate program now, so we should understand this. And then clinical experience is that pattern recognition. When you've treated, I'll give you just a quick example. My first clinic that I worked in, probably 70 visits a week that I would see, with 95% of them being back or neck issues. So I was seeing roughly 240 visits a month of spine, over 2,000 spine visits per year. And I got really familiar with seeing spines, really comfortable with seeing spines. So I have a lot of N, I have a very large N to choose from, and so it's easier for me to see patterns because I've seen patterns for so long now for spine. Errors. Making assumptions without checking. Please don't do this. Just because, roughly 80% of your patients are derangement and 80% of those are an extension responder, don't just assume you have an extension responder. And also, if the patient doesn't get better with extension, don't assume that the patient's not mechanical or that MDT doesn't work. That's another poor conclusion to come to. Prematurely limiting your hypotheses, I like to do with my students just like one big whiteboard. In my head the whiteboard's there, but I like to do like one big whiteboard. Let's write down every possibility that this could be. Start ruling these things out one by one. Okay, it's almost like an episode of House. I can remember in PT school, I think it was Dr. Ryan's class, which, shout out to Jennifer Ryan. She's an amazing professor. If you get the chance to take a CEU with her, she's awesome. And we would watch episodes of House, and we'd play the whiteboard game, and try to figure out how fast we could get to the problem. Anyway, failure to gather enough information. Failure to listen to the patient. Oh my gosh, please listen to the patient. The patient has all the answers, right? The patient is going to feed you the answers if you're actually listening. The patient is going to feed you the problems, and they're going to feed you the solutions. So even if you do nothing else other than listen to the patient and just do what they tell you helps them, man, you've already got a head start. So listen to the patient. Sorry about that. That's sorry, that's work actually. I got to cut this presentation a little short. Back at it. Guys, I will be back to come back to errors in clinical reasoning. Give me a few minutes.